Hello everyone. So today we'll be discussing about collateral ventilation in Chartis system. So this is one of the table from Gold Guidelines, which says about surgical and intervention therapies in advanced emphysema. So in cases of emphysema, predominantly a phenotype with hyperinflation, you have to see whether there is a bulla or there is no large bulla. If there is no large bulla, then you come across heterogeneous and homogeneous emphysema. Then you check for the CV and FI, where CV stands for collateral ventilation and FI stands for fissure integrity. And then you take a decision whether you want to put a coil, you want to put a wall, or you want to do a surgery or vapor ablation or whatever it is. So basically, have you ever thought about what is heterogeneous, what is homogeneous in emphysema? Why collateral ventilation? If present, then you can't put a valve. If it is absent, then you can put a valve. What is fissure integrity? So we'll be dealing with all these terminology in detail in this presentation. So as you know, there are interalveolar connection which are known as pores of cone, which connect one alveoli to other alveoli. Then you have canal of Lambert's, which connect alveoli to bronchiole. And then you have channels of Martin, which connect bronchiole to bronchiole. This is a diagrammatic representation of the same what we have discussed in the last slides. What is collateral ventilation? It is basically the movement of air between two adjacent segments or lobes through these pathways that we discussed in the previous slides. In a healthy lung, the flow through these channels will be minimal, almost nil, because of the tight interalveolar structures. But in case of emphysema, where the alveolar walls are damaged, this flow through these pores and channel become more prominent. And why it is important before we proceed to any bronchoscopic lung volume reduction? Basically, the main aim of putting a valve is producing a lobar atelectasis in the targeted lung where we have put the valve, that is one-way valve. So air will only come out, it will not go in. Eventually, that part which is not getting ventilated will collapse only and only if it has no collateral ventilation. If it has collateral ventilation, putting a valve will be a failure actually. So how do you measure now collateral ventilation? So there is a system called Chartis system. So there is a balloon catheter. So there is a inflatable balloon at the tip. You can put this balloon catheter through a normal 2.8 mm working channel or maybe a larger one. And then there is console, which measures the flow as well as the pressure. So basically what happens during the procedure, through the bronchoscopic working channel, this balloon tipped catheter is inserted into the target locus segmental bronchus. The balloon inflates and it isolates the lobe from rest of the lung. And then you can check on the system, the airflow and the pressure buildup. So this is the system. This is under conscious sedation. This is under general anesthesia. Here you can see the flow is coming to zero gradually and pressure is getting built up gradually. So here is the place where there is no collateral ventilation and it is an ideal case of putting a valve. But in this case, the flow never reaches the zero and there is no building up of pressure also. So collateral ventilation is present. It will be a treatment failure if you put a valve here. And in general anesthesia, you basically check for flow. So in the Chartis system, the balloon is inflated within the lobar bronchus, blocking the airflow into the targeted lobe. The median time for which the balloon is inflated is around 240 seconds. You can measure the expiratory flow, inspiratory pressure, and the ratio between the two, which is called as resistance. So if a patient is having continuous expiratory flow for more than 5 minutes, despite blocking this airflow into the targeted lobe, or there is exhaled volume of more than 1 liter. This suggests that there is collateral ventilation present, and that is not an indication for putting a valve. Gradual decline and eventually cessation of complete flow indicates the absence of collateral ventilation, and it is an ideal case of putting a valve. Now, it has to be done under what? Conscious sedation or general anesthesia. So for conscious sedation, you are using IV propofol, remifentanil. So these can be titrated to a level where patient is sedated but still arousable and breathing spontaneously. And the other one is GA, where you basically intubate the patient and you give muscle relaxant also, that is rocuronium bromide. So conscious sedation can be challenging and it has almost the same challenges that we face during a normal bronchoscopy, like increased cupping, mucus secretion, bronchoconstriction, mucosal swelling, and difficulty to maintain an optimal level of sedation. So, GA is nowadays preferred and it is recommended as a technique for both the measurement of collateral ventilation via Chartis as well as placement of endobronchial valve. So, there is an ease of airway and patient management. So, these are the landmark trials: Chartis trial, Stelvio trial, Impact trial, Transform trial, Breathackers registry related to. So coming to the endobronchial valve, the valve is known as Zephyr valve. So the procedure is very minimally invasive bronchoscopic procedure. So the trapped air in the non-ventilated lung escapes through these Zephyr valves until the lobe volume is reduced, and the remaining lobes are then able to expand more, work more efficiently. There is decrease in the pressure on the diaphragm, and overall the lung functions improve. It is generally a 1 hour procedure. Around 3 to 5, on an average, 4 walls are placed during a procedure to completely occlude the lobe. These can be easily removed or replaced if needed, and a duration of around 3 nights stay post procedure is needed in this. Silicon ductile, it was the first and FDA approved wall. It has a self-expanding nitinol frame and a single wall diameter size. Basically, it exerts a radial force onto the airway wall. It is fatigue resistant, so prevent fracture and fragmentation. Anchorless fixation that gives you an easy and atraumatic removal with a migration rate of less than 1%. And it also allows for a partial deployment method. So there is an easy and accurate placement. So it comes along with these delivery catheters. Now, coming to homogeneous versus heterogeneous ventilation in emphysema. So, homogeneous ventilation means even distribution of airflow. So, basically, the lung tissue experiences similar level of ventilation across different regions. There is more severe airflow obstruction. So, these patients with homogeneous emphysema, they'll tend to have a significant reduction in airflow. Then they'll have a strong association with collateral ventilation and the potential for lung volume reduction therapy. So basically, they will benefit more with the lung volume reduction procedures. Coming to the heterogeneous ventilation, so they basically exhibit areas of good ventilation, then there are areas of poor ventilation or air trapping. So though the airflow obstruction is present, but it can be comparatively less as when we compare it to homogeneous emphysema. It may or may not be associated with a very significant collateral ventilation, and the heterogeneous nature of this disease make its like more individualized approach to the treatment. So here you have more potential for putting an endobronchial wall, and that will be more successful as compared to the homogeneous emphysema. So now you must have read in all the guidelines and book that if we are talking about LVRS, either bronchoscopic or surgical, if the disease is in the upper lobe, the procedure has more favorable outcome. So why is it so? So basically, the upper lobes, uh, if they are affected, they contribute very little to the gas exchange and they are more of dead space and hyperinflation. So if we basically collapse them via endobronchial walls, so they will actually reduce the total lung volume, allows the healthier lower lobes to re-expand, and thus improving the VQ matching. Then gravity dependent physiology. So basically, in a standing or a sitting person, the lower lobes are better perfused due to gravity. So removing upper lobe hyperinflation will allow a better mechanical expansion and a gas exchange in a functionally stronger lower lobes. Basically improves exercise capacity as well as dyspnea score. Then whatever evidence we have in the literature or via the trials, whether it is net trial or we have the studies on Zephyr walls or spiration wall, they have included mostly the patients who have upper lobe disease. Then anatomical favorability. So the fissure, especially the oblique fissure, which is between the upper and the lower lobe, they are often more complete. So thus indicating a low collateral ventilation and a higher success rate for inducing a lobar collapse post valve placement. Lower lobes sometimes they have some intersegmental connection, so a less predictable candidate. And last is predictable collapse and a better targeting. So upper lobe, they tend to collapse more cleanly when they are blocked with the walls. So the result of Chartis are more reliable and the fissure completeness on HRCT is easier to interpret actually. So from whole presentation, the main breath hacking pearls are that heterogeneous emphysema is preferred, upper lobe predominant is preferred for ball placement. There should be complete fissure or fissure integrity with no or minimal collateral ventilation. Significant hyperinflation should be there with an increase in residual volume and TLC on the body volume measurement, and the patient must be symptomatic despite optimal medical therapy. So if a candidate has these more of these features, he or she is an ideal candidate for endobronchial valve. Thank you all. If you like the presentation, please like, share, and subscribe.